Hi, I'm Dr. Chris Lewis, one of the chief educators here at Doctors in Training. And today we're continuing our pharmacology lectures and we're talking about cholinergic antagonists. And no, this has nothing to do with your colon. This has to do with other things entirely. So the first thing we need to talk about is the autonomic nervous system. Now, this can be a confusing topic for many students. There's multiple receptors and multiple neurotransmitters. There's autonomic versus somatic. There's sympathetic versus parasympathetic. So how are we going to get all this into our brains? Well, I'd advise that you watch one of our other lectures first. Now, there's one specifically on the autonomic nervous system. Very well done, and it'll show you the ins and the outs of the autonomic nervous system, and will lay the groundwork for several of the other lectures that we'll have regarding this topic. Now, today we'll briefly review some of these topics from that lecture, but to get the full story, then I'd go back and watch that one if at all possible. So let's start with a brief review of the autonomic nervous system. So first let's talk about the sympathetic nervous system. So what goes on with the sympathetic nervous system? Remember, easy, fight or flight. So this is the times when you need to run or when you need to fight something or get away. So what are the typical signs and symptoms of the sympathetic nervous system stimulation? Well, you get pupillary dilation or mydriasis. You get increased heart rate. You get increased heart contractility. You get decreased GI motility. You don't want to have a bowel movement while you're trying to run away. Dilation of peripheral blood vessels. So you want to get as much blood to the peripheral muscles as possible so you can run away really fast. You get thick viscous secretions. I'm not exactly sure why that's helpful. I guess so you're not drooling while you're running. But all of these things, it's pretty obvious. You want to increase that heart rate. You want to do all these things in order to beef up your musculature and to get away or to fight. Now, for the parasympathetic nervous system, this is our rest and digest. So if you can just think of the opposite reaction from sympathetic, then you generally get the parasympathetic nervous system stimulation. So pupillary constriction or meiosis. You get decreased heart rate. You get decreased heart contractility. You'll get increased GI motility. So this is the digest part. So you're not needing to run away, so you can have a bowel movement. Copious watery secretions. So just the opposite of the thick viscous ones that we get with the sympathetic. Relaxation of the bladder sphincter, so you can now urinate. You don't have to run away, so now you can actually relieve yourself. Now, there's also an enteric nervous system that we won't really go into much detail here today, but it controls the GI system, and it's a very, very complex, very large nervous system. It's considered the brain of the gut, so realize that there's that nervous system as well. Let's also talk briefly about neurotransmitters and receptors, because that can be very, very confusing as well. So our typical neurotransmitters that are at least most clinically important to us include acetylcholine, which is a huge one, norepinephrine, epinephrine, dopamine, serotonin, and histamine. So those are the big ones that we run into, the ones that we have pharmacologic interactions with. And then our major receptors, the ones we're going to talk about today, especially that are related to our autonomic nervous system or our somatic nervous system: nicotinic receptors, muscarinic receptors, and adrenergic receptors. And we're going to talk a lot about the nicotinic and the muscarinic today. Now, I want you to look at this graphic here for a minute. I want you to look at the types of receptors and the types of neurotransmitters that are important in our nervous system. So you'll notice that in our autonomic nervous system here, we have our ganglia here, which you can kind of think of as relay stations. They're not getting all the way to the effector organs. Your nerve transmissions need to sort of go through this relay station called the ganglia. And we don't have it labeled here, but these are nicotinic receptors. And then you'll notice when you get down to the effector organs, you'll see parasympathetic versus sympathetic. Now, you'll notice specifically here on the parasympathetic effector organs, we have muscarinic receptors. So remember that, muscarinic receptors on parasympathetic effector organs. Also over here on the somatic side, you'll notice that we have nicotinic receptors on the effector organ as well, and that's the skeletal muscle. All right, so now in this lecture, we're going to concentrate on the antimuscarinic agents. So that's going to be a big part of our lecture. We're also going to talk about ganglionic blockers. Remember how we have those relay stations. And then we're also going to talk about neuromuscular blockers right on those skeletal muscles. So first we're going to go to the antimuscarinic agents, sometimes referred to as antimuscarinics. Occasionally you'll have people call these anticholinergics, though that's not really technically accurate. So if you can remember, try to refer to these as antimuscarinic agents because it actually works on the muscarinic receptors, so that's important. So these agents, as I just mentioned, block muscarinic receptors. And where did we see these receptors? That's right, at the parasympathetic effector organs. That's where you're really going to see most of the action here. Most of the time, sympathetic neurons use epinephrine and norepinephrine with adrenergic receptors, but the sweat glands are sympathetically innervated with muscarinic receptors. Now, muscarinic receptors are not found in skeletal muscle. What receptors were found in the skeletal muscle that we just talked about a second ago? Nicotinic receptors. So nicotinic receptors in the skeletal muscle, and then these muscarinic receptors in the parasympathetic. So let's talk about a drug now. Let's talk about atropine. Now this is probably the most recognized antimuscarinic drug. It's found in the plant Atropa belladonna. It's also known as deadly nightshade, and that's a really cool name. If I were a plant, I'd want a name like that. I bet you all the other plants are probably jealous of deadly nightshade because that's just cool. It's also known as Jimson weed or Jamestown weed. Also, it's an interesting fact that belladonna is Italian for beautiful lady. So why would we call deadly nightshade also a beautiful lady? Well, this is because in the Renaissance era, dilated pupils were considered attractive. So women were using eye drops from the extract of the plant to dilate their eyes. So they'd walk around, they couldn't see very well, but they were very attractive. So belladonna and that kind of go along with the attractive pretty lady syndrome. All right, so mechanism of action. So these bind competitively to muscarinic receptors that we've talked about before. It blocks acetylcholine from binding to the receptors, and it blocks it from eliciting its usual response. So it doesn't do anything to the neurotransmitter acetylcholine itself. It's just getting to that receptor and preventing acetylcholine from doing its own effect there. So in general, we're blocking parasympathetic action. So except for those two exceptions in the sympathetic. So let's talk about these actions. So first, let's talk about the eye. We've already talked about the belladonnas. So blocking parasympathetic action in the eye will result in mydriasis or pupillary dilation. It also results in cycloplegia. So this is important to know as well because this makes it so you can't accommodate the pupil. So you can't focus very well. So people are going to walk around relatively blind. And the pretty ladies would look good, but they couldn't see where they were going. So they probably bumped into people. Now, you want to be very careful in the setting of narrow angle glaucoma because you can actually increase intraocular pressure and cause worsening of the syndrome as well. So you don't want to use atropine in narrow angle glaucoma. Let's talk about how it affects our gastrointestinal system. So atropine can cause a decrease in motility and a decrease in secretory functions. I want you to remember, though, that the GI system was also controlled by the enteric nervous system, which is not fully inhibited by antimuscarinic drugs. So even though you can use antimuscarinic drugs to affect the GI tract, it's not a complete blockade, so it's not going to work quite as well as some of our other medications that we use. But you do have a pretty marked effect on salivary secretion, so dry mouth is very, very common with these medications. Respiratory system. So it causes bronchodilation and reduced secretion. So we'll talk about some inhaled antimuscarinic medications a little bit later that are helpful in asthma and COPD. So remember, atropine, antimuscarinics will cause bronchodilation and reduced secretion. How does it affect our cardiovascular system? Well, moderate to high doses will cause tachycardia. Now, there's a constant parasympathetic effect on the heart, keeping the heart rate normal. So if the heart was left to its own devices, it would beat relatively quickly. Now we have this sort of constant, I imagine a constant parasympathetic hand on the heart. It's kind of holding back the heart, slow down heart, slow down heart. And if you remove that parasympathetic tone, say with atropine, you get tachycardia. So just remember that constant parasympathetic tone being removed, causing that tachycardia. Now, low doses can cause an initial bradycardia, but in general, eventually you're going to get to a tachycardic situation. Let's talk about how it affects our urinary tract. Well, it causes relaxation of smooth muscle of the ureters and the bladder wall, and it can slow voiding. So you can get urinary retention in this situation. Sweat glands. Now, it suppresses thermoregulatory sweating. Now, large doses are needed in order to affect adults. So if adults are taking atropine or other antimuscarinics, they're not going to get a whole lot of fevers or elevated hyperpyrexia. But children, on the other hand, are very different. They're very, very susceptible to even low doses of atropine and other antimuscarinics. So you can have a rapid increase in temperature in children. So you have to be very, very careful, if ever using these medications in children, that you don't give them too high of a dose because they're going to have some high temperatures. So let's talk about therapeutic uses of atropine. So we've already talked about the eye. So there's an ophthalmologic use for these medications, sort of. We don't really use it much anymore. But you can use this topically to cause both mydriasis and cycloplegia, which is, again, the inability to accommodate. Now, this can be helpful for eye exams, but the effects are very long-lasting, 7 to 14 days. So would you want to dilate your eyes for 7 to 14 days? I guess if you're an Italian woman in the Renaissance era, you'd want that. But if you just want to go in for an eye exam, you probably don't want to be dilated for 7 to 14 days. So atropine is almost never used. I've never heard it used personally because there's other medications that can do the job just as well and last much shorter period of time. Like phenylephrine is often used. Some of the other alpha adrenergic agents, which we have a lecture on, are much shorter acting, and we use those much more often than we would ever use atropine. GI. So remember how we talked about this will slow down motility? Well, rarely is it really used alone for any GI problems, and we're talking about atropine. But it's very commonly used in combination with diphenoxylate, and this is an opioid antidiarrheal, so it's an anti-diarrhea medication. Now, the question is, well, how much is the atropine really contributing to the antidiarrheal effect? Well, maybe a little bit. But it's the diphenoxylate that works mostly as an antidiarrheal agent. The presence of the atropine is very helpful, though, because diphenoxylate can be abused. It does have some opioid qualities, so you can cause some euphoria and some abuse. So the atropine is in there to help prevent people from abusing the drug. Well, how does that happen? Well, if you take too much atropine, you're going to have so many side effects that you're not going to want to take the medication. So it's almost in there as a deterrent rather than actually treating something. When else are we going to use atropine? Well, we're going to use it for an antidote for cholinergic agonists. So let's talk about this situation. So this occurs most often in patients who are exposed to pesticides or organophosphates. So in the situation where you have a farmer who's out spraying the crops with pesticides, a lot of these substances are what we call cholinesterase inhibitors. Now, in the synaptic cleft of the cholinesterase inhibitor, the cholinesterase inhibitor will prevent the degradation of acetylcholine. So acetylcholine usually goes in the synaptic cleft, and then a cholinesterase will come in and cleave it, and then acetylcholine is no longer useful at that point. Well, if you have these inhibitors in there, then there's a buildup of acetylcholine. Acetylcholine is able to float around in greater concentration, so you get this overdose of cholinergic activity in the synaptic cleft and in the body. So patients will present with sweating, drooling, mental status changes, fever, so just basically the opposite effects of atropine. Very large doses of atropine may be needed to counteract the activity of the cholinesterase inhibitor. So you're trying to block those receptors because there's just too much acetylcholine in the synaptic cleft. Now, if you get a question about a drooling farmer, and I promise you will, because this is such a fun question to write, is that you've got a farmer who comes in and he looks all flush and he's drooling and he's altered. Always think of organophosphate poisoning. Always think of this cholinesterase inhibitor overdose, and that you need to use atropine to counteract it. Antisecretory effects, we talked about a little bit of this with GI as well. Occasionally atropine can be used to decrease salivary secretion or in patients with hyperhidrosis or excessive sweating. So if someone has really, really horrible sweating, you can use atropine in that clinical situation. So let's talk a little bit about pharmacokinetics. Well, it's absorbed in the GI tract, it's metabolized by the liver, it's excreted in the urine, and the half-life is about 4 hours, so it's not terribly long. Adverse effects. Now, this is an important test question as well. You're always going to get anticholinergic or antimuscarinic effects on a question somewhere. And we have the nice memory tool. The first one is hot as a hair. So you're going to have increased body temperature. The next one is dry as a bone. So you're going to get dry mouth. Red as a beet. You're going to get flushed skin. Blind as a bat. or blind as a pretty Italian girl in Renaissance era. Remember, you get your cycloplegia, paralysis of the ciliary muscles, so you can't accommodate, and you're also going to get a lot of mydriasis as well, so you might be getting a little too much sun or light into your eye. And then mad as a hatter, you're going to get disorientation, delirium, bloated as a toad. So constipation, urinary retention. So remember all those: hot as a hair, dry as a bone, red as a beet, blind as a bat, mad as a hatter, bloated as a toad. You might know this stuff already, but always good to remember. All right, so the next medication we're going to talk about is scopolamine. Very commonly used medication. Again, this is another antimuscarinic agent. It has similar peripheral effects as atropine, but it does differ in that it penetrates the CNS or central nervous system more than atropine. Atropine generally doesn't get into the CNS quite so much. So when are we going to use this medication? How is it different from atropine? Well, this is used almost exclusively for motion sickness, and it's probably the most popular medication for motion sickness. It can be taken orally, it can be given IV or IM, but most commonly this is used in a transdermal patch. So you'll have the patient place the patch behind their ear when they fly or when they get on a boat or whatever causes them to get nauseous. And it can be very, very effective. It's probably the most effective anti-motion sickness drug that we use. Now, it does have an effect on short-term memory, usually not so much with the patch. Most of the time it's with a little bit higher doses if you're giving it IV or IM. And it can slightly decrease secretions as well. So sometimes this can be used as an adjunct to anesthesia. So you'll see anesthesiologists potentially using this medication, especially if someone has a lot of secretions, and it does kind of help them, the patients not remember the process of being intubated and going through surgery and all that stuff. Adverse effects are similar to atropine, so just tell people if they're going to go on their boat ride, they need to stay well hydrated, because I do have people complain of dry mouth when they take their scopolamine. But good medication and easily taken off, easily put on, so it's a nice thing to be able to take on your cruise or wherever you're going to go. All right, our next couple of medications are called Epitropium and Tiotropium. So these are very commonly used medications, and these are different because they're inhaled antimuscarinic agents. So we've been talking about oral or IV or IM medications. These are our inhaled antimuscarinic agents. Now recall how the antimuscarinics can produce bronchodilation through relaxation of smooth muscle and decreased secretions in the lungs. So remember, we talked about bronchodilation with these medications, and this is where we're going to use them. Now, one benefit of these medications being inhaled is that their effects are only felt in the lungs. So there's no systemic absorption, so you don't get quite as many of the other side effects associated with the antimuscarinics. They're really concentrating their effects in the lungs, which makes them quite nice. Now, they're used often in patients with COPD or chronic obstructive pulmonary disease. They're occasionally used in asthma as well, and they're good medications. Now, tiotropium is a newer medication, and it has a longer duration of action and can be given once per day. It is a little bit more expensive than epitropium, so sometimes epitropium is used in certain situations where cost is an issue. But tiotropium is not that bad anymore in regards to cost. So being able to take a medication just once a day is nice, rather than having to give it 2 to 3 times a day in comparison to the epitropium. All right, so we're moving on to some eye drops. This is tropicamide and cyclopentylate. So these agents, again, are antimuscarinics, but they are only used for ophthalmologic purposes. They are in solution form, so they're used as eye drops. They produce mydriasis, cycloplegia, similar to that of atropine. Again, their duration of action is longer than some of our other alpha medications, but it's still shorter than atropine. You know, atropine, we were talking about 7 to 14 days. Well, these are more on the order of 6 hours and 24 hours for cycloplegia. 6 hours is for the mydriasis. Still, we're not using these medications just extensively, because we have even shorter acting medications that can be used, so you're not walking out of the ophthalmologist's office with your eyes just completely blown out. So, but remember those two medications, they are used sometimes.
Now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time to read your pharmacology text that corresponds to the material that was just discussed. Then together we'll go through the quick review in the study guide.
All right, pay attention. Say you're treating a patient with atropine and she has sudden onset eye pain. What just happened? Well, wrong. Wrong, wrong, wrong. Atropine can cause acute angle closure glaucoma. Why don't you just quit wasting my time and go back to flipping burgers or mowing lawns?
Hi, I'm Dr. Mike McInnes, and I'm here to go over the quick review number 1 in your study guide. First question, in what ophthalmologic disease should you not use atropine? The answer we're looking for here is narrow angle glaucoma. So why is that a problem? Dr. Lewis mentioned this several times, but what does atropine do to the eye? It causes dilation of the pupil, which is really contraction of the radial muscles of the iris. That's what makes the pupil enlarge. In a patient with a narrow angle between the iris and the cornea, contraction of the iris can potentially impede the drainage of aqueous fluid. So the fluid builds up and the pressure builds up. Another way to remember this is that we treat acute angle closure glaucoma with pilocarpine, and this is a muscarinic agonist. So we should avoid the antimuscarinic drugs such as atropine in these patients. Next question, which type of patient is more susceptible to the hyperpyrexia effects of atropine? Well, these are pediatric patients. In general, the very young and the very old are the two groups that are more susceptible to the anticholinergic side effects of various drugs. Next, what are the two benefits of combining atropine with diphenoxylate to treat diarrhea? So there's an antidiarrheal preparation that's a combination of diphenoxylate, which is an opioid, and atropine. And it's sometimes sold under the brand name Lomodal, either as a pill or a liquid. You may have heard of that. Opioids like diphenoxylate reduce GI motility, and they can cause constipation. Well, in a patient with diarrhea, that's a good thing, right? Atropine will also decrease GI motility, but the main reason that atropine is added is that atropine will decrease the likelihood of abuse of diphenoxylate. Diphenoxylate crosses the blood-brain barrier and can cause some euphoria. So to keep the junkies from just chugging it and to get high, we add atropine. So if they do chug it, they're going to get all those atropine side effects like dry mouth, dry eyes, weakness, and nausea. Next question. What's the most common way to administer scopolamine? Well, we administer scopolamine usually as a transdermal patch. And the instructions for the drug say to put the patch behind the ear when you're using it for motion sickness. So if you ever go on a cruise, you'll see a bunch of people walking around with these scopolamine patches behind their ear. It looks like little Band-Aids stuck on their ear. I'm not really sure it works any better to put it behind the ear than anywhere else on the skin, but that's what the instructions say. Next, what are the effects of atropine on the respiratory system? So atropine can cause bronchodilation and also reduced secretions. Next, which inhaled antimuscarinic drug has a longer half-life and can be dosed once per day? So for the longest time, the only antimuscarinic drug we had for COPD patients was Epitropium, but it doesn't last very long, so patients had to keep puffing it several times a day. Now we also have a drug called Tiotropium, which has a nice long half-life, so you can give it just once a day. That's the end of this quick review. Now let's go back to Dr. Lewis.
All right, we're switching gears now to a whole new category of medications. We're moving on to ganglionic blockers. So remember, we talked about the ganglions. They're being the relay station for our innervations here. Now, these agents act on nicotinic receptors on both the sympathetic and the parasympathetic ganglions in the autonomic nervous system. Even though they are nicotinic receptor blockers, they're not acting on the somatic muscles. So let's look back at our diagram. So here we have nicotinic receptors in the autonomic nervous system. We don't have these ganglionic receptors labeled, but they are nicotinic receptors. So we're blocking the sympathetic and the parasympathetic nerves. Therefore, these drugs are basically blocking all the output from the autonomic nervous system. So you have to ask yourself, when do we want to use these medically? Well, the answer is pretty much never. We don't want to just completely knock out our autonomic nervous system. Because these actions are so nonspecific and unpredictable, we just don't have a good reason to use ganglionic blockers. So we'll talk about one medication that I guess has been used at some point. I've never used it before. But I do want to talk about nicotine itself. So nicotine will obviously bind to nicotinic receptors. That's why they're called nicotinic receptors. So in a certain sense, you can think of these as being a blocking agent on the ganglion because it is nicotine itself. Now, what generally binds to the nicotinic receptors in the body? Well, it's acetylcholine, so don't forget that. Just because it's called a nicotinic receptor doesn't mean that our body is spewing out nicotine in order to activate these ganglion and affect some of the other receptors. So remember, acetylcholine is the normal neurotransmitter that's affecting this receptor. Now, of course, you already know that nicotine is present in cigarette smoke and has many negative effects on the body. But let's talk about its mechanism of action real quick. Nicotine binds to the nicotinic acetylcholine receptors in the CNS. Now, nicotine in the CNS will result in increased levels of dopamine, and this is what's responsible for the euphoria and the relaxation and addiction caused by a nicotine consumption. So that's why it's so hard to quit smoking. So nicotine activates the sympathetic nervous system as well, because remember how those ganglion are activated by nicotinic receptors in those ganglia. So you're getting an uptick of your sympathetic tone as well. So you get more epinephrine release. Let's talk about the action. So in the CNS, low doses produce euphoria, arousal, relaxation. That's why smoking is so much fun. It can improve attention. You can improve learning and problem solving and reaction time. Nicotine is an appetite suppressant. So far this is looking like a great little drug here. Why don't we take this all the time? At very high doses, you can get central respiratory paralysis, so that's not so good, and severe hypotension. Cardiovascular stimulation of that sympathetic nervous system will result in an increase in heart rate and blood pressure. You can get vasoconstriction of peripheral vasculature, and this can worsen peripheral vascular disease. Nicotine decreases coronary artery blood flow and can affect patients with angina. So those are all pretty much negative there. Pharmacokinetics, highly lipid soluble, so it crosses the blood-brain barrier very, very easily. It takes 7 seconds for nicotine to reach the brain when it's inhaled. So this is a very fast-acting drug. Half-life is about 2 hours. The average smoker takes in about 1 to 2 milligrams of nicotine per cigarette. Things like chewing tobacco, dipping, snuff, these tend to provide a much greater amount of nicotine, but this is hard to predict on how much you're putting in your mouth, how long you keep it there, and all that type of stuff. It's metabolized in the liver by cytochrome P450. Be aware of that and other drugs. Glucuronidation and oxidative metabolism of nicotine is inhibited by menthol, which increases the duration of action of nicotine. So this is why we have menthol or mentholated cigarettes. So it increases the action of that nicotine in the body. Adverse effects. So irritability, tremors, GI cramping, diarrhea, tachycardia, increased blood pressure. So quite a few negative things. Now, it's pretty unlikely that a person can overdose on nicotine through smoking alone. Remember how we talked about you're only taking in about 1 to 2 milligrams of nicotine per cigarette. Though intoxication can occur through the excessive use of nicotine patches, gum, and nasal sprays or oral inhalers. So I've probably heard of the story where someone comes in sick and they're trying to quit smoking and they've got 17 patches all over them and they're chewing gum and they don't feel very well because they're overdosing on nicotine. Now, there is a situation where you can spill a high concentration of liquid nicotine on the skin, and this can cause intoxication or even death since nicotine readily passes into the bloodstream following dermal contact. So most of the time people aren't coming into contact with high concentrations of nicotine solution, but there's one situation where you could potentially die from nicotine. Other than having a heart attack or some of the other problems, but just nicotine in and of itself killing you. So in pregnancy, nicotine can cause increased risk of spontaneous abortion, placental abruption, placental previa, preterm labor, and low birth weight. So all negatives there as well. The other big problem with nicotine is that there's withdrawal symptoms. So irritability, anxiety, restlessness, difficulty concentrating, headaches, insomnia, all these things obviously are not much fun to go through. Very difficult to quit. It's similar, if not worse, than quitting heroin or cocaine. So when people say they can't quit smoking, it's just too hard, they're not lying. They're really going through some serious withdrawal symptoms when they're trying to withdraw off of nicotine. Smoking cessation programs can be very helpful. Nicotine replacement, so we talked about the patch, the gums, the inhalers, the electronic cigarettes. There's lots of interesting ways that people can get nicotine into their body. There are a couple of medications. Epitropium is an antidepressant that can reduce the craving for cigarettes and can be helpful. There's a newer medication, varenicline is a new one. It's a partial agonist at the alpha-4 beta-2 neuronal nicotinic acetylcholine receptor, so same receptor here. But it's nice because it produces less euphoria because it's only a partial agonist. Now it helps with the nicotine craving. It can attenuate that rewarding effects of nicotine. So even after you stop taking the medication or while you're on the medication as well, people can still smoke. They're not going to get sick or have problems, but that smoking just won't feel as good. I'll have patients come in after taking varenicline and they'll say, I smoke and I just don't like it anymore. And I'm like, great. Sometimes they're not that happy about that because they sort of miss it, but it's no longer providing that rewarding effect that it used to. Side effects are significant with varenicline, so you need to tell people. They can have some really tripped out, vivid dreams. I'll have people come back just wild-eyed, like I had some weird stuff going on in my brain last night, so you need to tell them about that. Sometimes it's not as bad in other people. The very important thing you need to tell people is about mood changes. People can get depressed on varenicline. You do not want to forget to tell them that if their mood changes dramatically, that they need to stop the medication, let you know, because people who even didn't have any significant mood problems in the past can have significant depression. And those who have a history of major depressive disorder, you really got to make sure that these people are stable before you even think about using this medication, because it can make it worse. All right, so we're going to talk about the one ganglionic blocker that has been used clinically in the past, though I said before, I've never seen it before. Mecamylamine. This is a ganglionic blocker. It is a competitive blocker. When it's used to lower blood pressure in emergency situations. So if someone's having malignant hypertension, potentially you can use this medication. The duration of action is about 10 hours, and it is orally administered. Again, I've never seen this used before. All right, our final topic here is neuromuscular blocking drugs. So these drugs do exactly what their names say. They are blocking at the neuromuscular junction. They block the binding of acetylcholine to the nicotinic receptors on muscles. Now, before we were talking about hitting the nicotinic receptors in the ganglia. Now we're hitting the nicotinic receptors on the muscles. So think back to our diagram before where you see that somatic side, you see the muscle, you see no ganglion, but you see that nicotinic receptor being activated by what? Acetylcholine. So structurally, these drugs are very similar to acetylcholine. So they're going to be very similar in nature and in chemical composition. They are categorized as either non-depolarizing or depolarizing drugs, and we'll divide these up and tell you about them. Primarily, they're going to be used to produce muscle relaxation for surgery or anesthesia. They can also be used for rapid intubation. So these things knock out all your muscle tone so you can have surgery, and so you can have a tube shoved down your throat if you're dying or all sorts of things. So first we'll talk about the non-depolarizing blockers. So this is tubocurarine, pancuronium, myvicurium, metocurine, doxycurium, atracurium, cisatracurium, vecuronium, rocuranium, and pipercuronium. Now these drugs, or at least one of them, goes way back. So in fact, in the 16th century, European explorers found that natives in the Amazon basin of South America were using curare on their arrows to paralyze the animals they were hunting. So way back hundreds of years ago, people figured out, well, if I put this on my arrow and I shoot a deer, that deer just goes boonk and falls over paralyzed. So a pretty nifty medication or weapon at that point. Now, tubocurarine was developed first, and this was for medical use in the 1940s. So it's still been a brand of medications that have been around quite some time. So let's talk about their mechanism of action. So at low doses, the non-depolarizing agents bind to the nicotinic receptors without depolarizing the cell. So this is preventing acetylcholine from binding, so it's getting in the way. Now this prevents, like I said, the depolarization of the muscle cell membrane, and this inhibits muscle contraction. Now, this is a competitive blockade, and it can be overcome by increasing the concentration of acetylcholine in the synaptic cleft. So this can be accomplished by using what we talked about before, these cholinesterase inhibitors. So like neostigmine, like edrophonium. So these medications will then increase the acetylcholine in the synaptic cleft, so you can kind of overcome this competitive block. Now at high doses, the non-depolarizing blockers can block the ion channels of the end plate, and this leads to further weakening of the neuromuscular transmission, and it reduces the ability of those acetylcholinesterase inhibitors to reverse the actions of the non-depolarizing agent. So if you put one of those cholinesterase inhibitors in there, you increase the acetylcholine in the synaptic cleft. Well, if you're using high doses of those non-depolarizing blockers, it's just not going to overcome that blockade, so that can be a dangerous situation. Now, these agents will affect the rapidly contracting muscles first. So think of facial muscles, eye muscles, the things that can have real rapid twitch. They're going to be paralyzed first. The next thing you're going to get fingers, you're going to get then your limbs, the neck and the trunk muscles, and then finally the last muscle, probably thankfully, is the diaphragm. So the diaphragm is the last muscle that gets paralyzed by these agents. Therapeutic use, we've talked about this already, used as an adjuvant in anesthesia during surgery. So you want to get people completely relaxed during surgery, and they're not going to fight intubation and all that sort of thing. Pharmacokinetics, all of these are given IV. They're not absorbed in the GI tract. They do not cross the blood-brain barrier. Many of these drugs are not metabolized, and their duration of action is dependent on redistribution of the drug throughout the body. Now, tubocurarine, pancuronium, myvicurium, metocurine, and doxycurium are excreted in the urine unchanged. Tracurium is degraded spontaneously in the plasma. Vecuronium and rockuranium are deacetylated in the liver, and their clearance may be prolonged in patients with hepatic disease, so remember that about rockuranium and vecuronium. And most of the time these medicines all work about the same, but what's different about all of them is that they have different durations of action and time of onset. So there are certain medications, especially rocuranium, that work very, very quickly, and for procedures like facilitating intubation, you might want to use that medication. Some of the other ones last a little bit longer, but overall there's not a lot of difference between them. Adverse effects. These are generally well tolerated. They do quite well with people. There's not a lot of side effects. Tubocurarine may induce histamine release and promote ganglionic blockade, so it can lower blood pressure, and now it's really rarely used, so you're not going to see a lot of tubocurarine made for that because you don't want to lower blood pressure, especially if you're trying to paralyze someone for surgery. You don't want their blood pressure going down. Pancuronium can actually cause an increase in heart rate, so be aware of that as its major adverse effect and how it differentiates itself from some of the other medications. Drug interaction, so this is important. Cholinesterase inhibitors, so the non-depolarizing agents can be counteracted by the cholinesterase inhibitors. Remember, that's what we talked about before. By inhibiting the degradation of the acetylcholine, you can greatly increase the amount of acetylcholine in the synaptic cleft. Though again, at high doses of non-depolarizing blockers, the cholinesterase inhibitors are going to be less effective. Another important test question that you might get, halogenated hydrocarbon anesthetics. So drugs like halothane, very commonly used, can enhance neuromuscular blockade by exerting a stabilizing action at the neuromuscular junction. So these agents sensitize the neuromuscular junction to the effects of the neuromuscular blockers. So if you use these medications with halothane, you might get a whole bunch of blockade, therefore your medications are going to work even more. Aminoglycoside antibiotics, things like gentamicin, tobramycin, can inhibit acetylcholine release from cholinergic nerves by competing with calcium ions. So they synergize with tubocurarine and other competitive blockers, so they enhance the blockade as well. Calcium channel blockers may increase the neuromuscular block of the competitive blockers as well, so don't forget about that. So let's talk about the depolarizing agents, and we really just have one medication to talk about, succinylcholine. So the depolarizing neuromuscular blocking drugs attach to the nicotinic receptor and act like acetylcholine. So the other ones were similar in structure to acetylcholine, but they didn't act the same way as acetylcholine. Remember, it prevented the depolarization. So these medications, they do depolarize the cell. So they're just like acetylcholine. However, where acetylcholine would immediately be broken down by acetylcholinesterase, that we've been talking about over and over again, these drugs remain attached to the nicotinic receptor, and they provide this constant stimulation to the nerve, or to the receptor. Therefore, when they're used, these agents first cause a transient twitching of the muscles, or fasciculations, and this is called the phase 1 block that goes on with this situation. Now, in time, the continued binding renders the receptor incapable of transmitting further impulses. So then there's a gradual repolarization, which is then resistant to depolarization, and you get this flaccid paralysis. So this is called the phase 2 block of the depolarizing agents. So though the mechanism of action is different, so remember one was depolarizing, one was non-depolarizing, the result is basically the same. You still get this flaccid paralysis when you compare the depolarizing to the non-depolarizing drugs. Again, the respiratory muscles are paralyzed last. You're going to get the fast twitch muscles first. Succinylcholine is the only clinically useful drug in this category. So that's nice. We had a whole bunch of drugs on the other ones, but succinylcholine is the only one on that one. It is very rapid acting with a very short duration, so several minutes. It's used for rapid endotracheal intubation, so that's nice. It can also be used for electroconvulsive shock treatment, so in order just to relax all the muscles so people don't tighten up. Adverse effects, very important, hyperthermia. So malignant hyperthermia, which is usually brought on by severe muscle rigidity and hyperpyrexia, can occur when given with halothane. So remember, that's our halogenated inhaled anesthetic. Treatment, if you do get the hyperthermia, treatment includes rapid cooling and then administration of a drug called dantrolene. This blocks the release of calcium from the sarcoplasmic reticulum of the muscle cells, so it decreases the ability of the muscles to contract, so you decrease that heat production and you get relaxation of the muscle tone. You can also get hyperkalemia, and this results from loss of tissue potassium during depolarization. And the risk is worse in patients with burns, muscle trauma, or spinal cord injuries, or obviously with someone with renal dysfunction. People can get a lot of post-op muscle pain, not uncommon. Bradycardia, and this can be from direct stimulation of the muscarinic cholinereceptors stimulations. And then apnea. So some patients have a deficiency in plasma cholinesterase and are thus more prone to have some prolonged paralysis of the diaphragm. So be aware if you're using succinylcholine, some people can be really sensitive to it.
Now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time to read your pharmacology text that corresponds to the material that was just discussed. Then together we'll go through the quick review in the study guide.
Double O, just the man I wanted to see.
Good morning, Q. What do you have for me today?
It's 1 in the afternoon, but that's besides the point. I give you rockuranium, a non-depolarizing neuromuscular blocker. Typically, it's used by anesthesiologists to provide skeletal muscle relaxation during surgery.
Fascinating. Bang-up job yet again, Q.
You have no idea how this can be useful, do you? When administered, it competitively inhibits cholinergic neurotransmission at the neuromuscular junction.
Cholinergic neurotransmitters, yes, that's what I thought.
It will rapidly paralyze your enemy within 2 minutes, beginning with the face, fingers, and finally limbs and trunk. Once incapacitated, you should have no problem retrieving the stolen plans.
Yeah, bravo, Q, but I don't think that'll be necessary. My next mission is a beautiful Brazilian named Sophia, whom I'd rather incapacitate with a couple of dry martinis and some charming conversation.
Yes, but its effects last just 45 minutes, and in an emergency, its effects can be reversed with neostigmine.
Thanks, Q, but once again, I've got this under control.
All right, let's go through the answers to quick review number 2 together. First question, what is responsible for the addiction of nicotine? This is increased levels of dopamine in the brain. Remember, nicotine is very, very addictive because of those high levels of dopamine that are achieved. Next, which neuromuscular blocking agents act very similarly to acetylcholine by depolarizing the cell? So there are lots of non-depolarizing neuromuscular blockers, all those cure drugs, myvicurium, rockuranium, but there's only one depolarizing neuromuscular blocker in common use, and that is succinylcholine. Next, the neuromuscular blocking agents affect which muscles last? Really, the muscle we're talking about here is the diaphragm. Next, what is the effect of halothane on non-depolarizing agents? Well, halothane will enhance the neuromuscular block. Next question, what's the potential adverse effect of combining halothane with a depolarizing agent? This is hyperthermia. You can get that malignant hyperthermia when you use a depolarizing neuromuscular blocker like succinylcholine along with halothane. Next, which non-depolarizing agent is the fastest acting and is therefore very useful for tracheal intubation in patients with gastric contents? So the fastest acting non-depolarizing neuromuscular blocker is rockuranium. Next, which non-depolarizing agent has the fastest recovery time and is therefore useful for short surgical procedures? Well, this is myvicurium. Next, which non-depolarizing agent spontaneously degrades in plasma and is the only non-depolarizing agent that does not need to be reduced in patients with renal failure? This is tracurium. So that's the end of our quick review. Now it's time for the end of session quiz. I want you to pause the video, answer the end of session quiz questions in your study guide, then restart the video and we'll go through the answers together. All right, let's go through the end of session quiz together. First question, why aren't cholinesterase inhibitors as effective at overcoming the effects of high-dose neuromuscular blockers? So remember, at low doses, you can give a cholinesterase inhibitor to overcome the neuromuscular blockade. But at high doses, that won't work. Why not? At high doses, neuromuscular blockers may block ion channels at the end plate, which is not overcome by increased acetylcholine. Next, match the following clinical descriptions with the most appropriate therapeutic agent. So first, a 53-year-old with end-stage renal disease is in the ICU and needs mechanical ventilation. So this would be tracurium. Remember, that one's the one that's okay to use in patients with renal failure. Next, a 27-year-old woman who gets motion sickness is going boating for a day. So the answer here would be scopolamine. Next, a 13-year-old child's eyes need to be measured for refractive errors. So you can use atropine for this. Dilate the eyes. A 31-year-old man wants to quit smoking. The drug we would use here is varenicline. Remember, that's the partial nicotinic agonist. And then finally, a 47-year-old man with bipolar disorder is about to undergo ECT, or electroconvulsive therapy. So you would use succinylcholine here. Now, on our list, there are two neuromuscular blocking agents. We would use succinylcholine here because it's short-acting, and that makes it better than tracurium, which is the other option here, because succinylcholine is only going to last for about 8 minutes, but tracurium is going to last about 90 minutes. Next question. Match the drug to the adverse effects. So, atropine can cause dry mouth. Nicotine causes tachycardia. Tubocurarine induces histamine release. Succinylcholine causes hyperkalemia. Next, match the agents below with their mechanisms of action. So nicotine is B, a ganglionic blocker. Scopolamine, A, antimuscarinic agent. Tubocurarine, C, a neuromuscular blocker. Atropine, A, antimuscarinic. Epitropium, A, antimuscarinic. Vecuronium, C, neuromuscular blocker. Mecamylamine, B, ganglionic blocker. And succinylcholine, C, neuromuscular blocker. Next, what are the adverse effects of atropine? So remember, we have this little mnemonic. We have hot as a hair for the increased body temperature, or hyperpyrexia. Remember, we see that more with children. Dry as a bone for the dry mouth. Red as a beet for flushed skin. Blind as a bat for the cycloplegia. Mad as a hatter for the disorientation and delirium. And bloated as a toad for the constipation and urinary retention. Next, which two antimuscarinic drugs are beneficial because their effects are only felt in the lungs, they have no systemic absorption, and they have fewer side effects? These are Epitropium and Tiotropium, the two inhaled antimuscarinic drugs. Next, a 32-year-old farmer presents with diaphoresis, watery eyes, drooling, and vomiting. What was he exposed to, and how do you manage this problem? Remember, Dr. Lewis warned you, beware the drooling farmer, didn't he? Remember, on your test, you're going to see a gardener or a farmer or somebody who's working in the yard applying pesticides. You need to think about organophosphate poisoning. So the organophosphates are covered in more detail in the lecture on the cholinergic agonist. But briefly, go over the management for this. First, organophosphates can be absorbed through the skin, so you want to protect yourself. Before you start touching the patient, put on gown and gloves. Second, the chemical can be on the patient's skin and clothing, so you want to strip off the patient's clothes and rinse their skin to make sure they're not still absorbing the organophosphate. Next is supportive care, airways, breathing, and circulation. You may even need to intubate the patient. Remember, you don't want to use succinylcholine for rapid sequence intubation. Succinylcholine is metabolized by acetylcholinesterase, so organophosphates are inhibiting this enzyme, and therefore you can get prolonged neuromuscular blockage. So don't use succinylcholine if you need to rapidly intubate these patients. Next, atropine. That's why we're discussing it in this lecture. Atropine competes with acetylcholine at muscarinic receptors, preventing cholinergic activation. You may also need to give a drug called prelidoxine. Atropine will antagonize the muscarinic receptors, but not the nicotinic receptors, which is where you're getting neuromuscular dysfunction. So Pralidoxime will reactivate acetylcholinesterase so the patient can start breaking down acetylcholine. Next question. What are the adverse effects of succinylcholine? So you can get hyperthermia, malignant hyperthermia with muscle rigidity and hyperpyrexia. And that can occur especially when you give this drug with halothane, which is one of those inhaled anesthetics. Next, you can get hyperkalemia, which results from loss of tissue potassium during depolarization. The risk of this is worse in patients with burns or muscle trauma or spinal cord injuries. Next, you can have post-op muscle pain because all that depolarization causes all the muscles to contract. So after they recover, they may have some post-op muscle pain, like a really bad workout. They can have bradycardia from direct stimulation of muscarinic colon receptors, and then they can also have apnea. Some patients have a deficiency in plasma cholinesterase and are thus more prone to have prolonged paralysis of the diaphragm. Next question. Both the depolarizing and non-depolarizing agents are similar to what neurotransmitter? Well, the neurotransmitter here is acetylcholine. And how are their mechanisms of action different? So depolarizing agents depolarize the muscle cell, while the non-depolarizing agents don't. That's obvious from the name. You also should know you get some muscle fasciculations and twitching initially when you use a depolarizing agent, but ultimately you're going to wind up with flaccid paralysis. When you use a non-depolarizing agent, you don't get that muscle fasciculation, you just go straight to the flaccid paralysis. And then finally, a patient has undergone surgery with the aid of a non-depolarizing agent. What can be used to reverse the effects of the non-depolarizing agent? Well, you'll use a cholinesterase inhibitor like neostigmine or edrophonium. Well, that's the end of our end-of-session quiz, and that's the end of our lecture on cholinergic antagonists. Hope you learned something. Good luck studying.